For decades, nonsteroidal anti-inflammatory drugs, NSAIDs and corticosteroids have been the primary tools for managing inflammation and pain in chronic conditions ranging from arthritis and tendinitis to autoimmune diseases. These drugs work well in the short term, reducing swelling, stiffness, and discomfort. But they treat the symptoms, not the cause. Their effects often fade with time, and long-term use can carry significant risks. Now, a new class of therapies, senolytics, is emerging with a radically different strategy. Rather than suppressing inflammatory pathways temporarily, senolytics aim to remove the upstream source of inflammation altogether: senescent cells. These dysfunctional zombie cells linger in aging or damaged tissues and flood the surrounding environment with inflammatory molecules, impairing healing and driving chronic disease. By clearing them, senolytics represent a shift not just in treatment, but in philosophy, from management to modification of the disease process itself. NSAIDs, including drugs like ibuprofen, naproxen, and celecoxib, work by inhibiting cyclooxygenase (COX) enzymes, which are key to producing prostaglandins, lipid compounds involved in inflammation and pain signaling. Corticosteroids, such as prednisone or dexamethasone, act on a broader range of pathways, dampening the immune response by inhibiting NF-B and other transcription factors. These drugs can provide quick relief, and in acute flare-ups or autoimmune crises, they're often essential. However, their effects are broad and nonspecific. They suppress both harmful and beneficial immune activity, and prolonged use can lead to ulcers, liver damage, cardiovascular issues, bone loss, and impaired immunity. Moreover, they don't address what caused the inflammation to arise in the first place. Senolytic drugs, by contrast, don't suppress inflammation directly. Instead, they target and eliminate senescent cells, which are a root source of many age and stress-related inflammatory signals. Senescent cells resist apoptosis, program cell death, and linger in tissues, where they release a pro-inflammatory cocktail known as the senescence-associated secretory phenotype, SASP. This includes interleukins like IL-6, growth factors, proteases, and reactive oxygen species, all of which can damage nearby cells, activate immune responses, and impair tissue repair. Senolytics work by selectively inducing death in these senescent cells, removing the inflammatory trigger at its source. This fundamental difference has profound implications. While NSAIDs and steroids suppress fire, senolytics remove the arsonists. Once the senescent cells are gone, the SASP dissipates, allowing tissues to return to a more youthful, regenerative state. This may explain why senolytics have shown effects that last weeks or months after a single treatment cycle in preclinical studies, something no anti-inflammatory drug can claim. In mice, senolytics have reversed physical frailty, improved cardiovascular and kidney function, enhanced insulin sensitivity, and extended lifespan, all without the need for daily dosing. In terms of mechanism, senolytics rely on identifying and exploiting vulnerabilities unique to senescent cells. For example, drugs like dasatinib and navitoclax target anti-apoptotic pathways such as BCL2 and BCLXL that senescent cells rely on for survival. Natural compounds like physidin and quercetin interfere with oxidative stress pathways and protein degradation systems that senescent cells use to maintain their dysfunctional state. These mechanisms are fundamentally different from the prostaglandin or steroid hormone pathways of traditional anti-inflammatories. From a safety perspective, senolytics are still under active investigation. Because they induce cell death, there is always a risk of affecting healthy cells if specificity is not precise. However, senescent cells have a distinct molecular profile, and early trials suggest that intermittent dosing may reduce side effects. In contrast, NSAIDs and steroids, though familiar and widely used, carry well-known long-term risks, particularly to the gut, kidneys, heart, and bones, and must often be tapered or cycled to avoid complications. Importantly, senolytics are not meant to be taken daily. Many are designed for intermittent hit-and-run dosing, reducing the risk of cumulative toxicity. When it comes to long-term outcomes, the most exciting promise of senolytics lies in their potential to slow or reverse the progression of chronic, degenerative diseases, rather than merely dulling their symptoms. In conditions like osteoarthritis, atherosclerosis, Alzheimer's disease, and even certain forms of chronic back pain, the presence of senescent cells is now recognized as a key contributor. Removing these cells could slow joint degradation, improve tissue resilience, and reduce pain in a more durable way than masking symptoms. While NSAIDs and corticosteroids may offer relief, they do not prevent underlying tissue breakdown and may even accelerate it in some contexts by impairing repair mechanisms. That said, senolytics are not a replacement for anti-inflammatories across the board. In acute settings, injuries, infections, autoimmune flares, traditional drugs still have an essential role. Senolytics are best viewed as strategic interventions for chronic, non-resolving inflammation associated with aging and long-term tissue stress. They are not painkillers in the conventional sense, but tools for reprogramming the biological environment toward repair and regeneration. Ultimately, the comparison between senolytics and traditional anti-inflammatories reflects a deeper shift in medicine, from palliative care to root cause intervention. If successful in humans, senolytics could become part of a new era in chronic disease management, not just slowing the spiral of degeneration, but changing its trajectory altogether. In doing so, they offer hope that aging need not be accompanied by persistent inflammation and unrelenting pain, that the drivers of decline may not be inevitable, but modifiable.